Oh, saya kena quit dulu sekejap ya.
Okay, boleh.
Okey, saya leave meeting dulu.
Okay, still got another 3 minutes to
Okey, saya akan share. Sekejap ya.
Dr. Sulaiman.
Ya, Waalaikumsalam.
Okey, sambil-sambil tu Dr. saya just nak make announcement.
Okey.
Pada mana-mana peserta yang ingin apply CPD point, kami tidak mohon ini di dalam portal KKM MyCPD 2.0, tapi saya minta sebaik untuk tuan-tuan dan puan-puan untuk mengisi borang kehadiran yang tertera di hadapan, sama ada dengan scan QR code ataupun menekan link yang diberikan daripada ruangan chat untuk kami isukan sijil, dan kemudian tuan-tuan dan puan-puan boleh memohon CPD di bawah unlisted program dengan menggunakan sijil berkenaan lah. Terima kasih.
Boleh nampak PowerPoint saya ke?
boleh nampak Doktor? Jelas.
Boleh.
Okay, thank you. So you all bagi signal kat saya lah, bila nak mula dan sebagainya.
Doktor dah sedia. Saya kira sudah sedia. Kira begini. Tak sabar ni. Doktor dah salam.
Okey, bolehlah.
Saya mulakan dulu. Bismillahirrahmanirrahim. Assalamualaikum dan salam sejahtera. Sekali lagi kita bertemu sekali lagi untuk sila E. Kita siri 2021 dan pada kali ini bertajuk Medical Legal and Issues Pertaining to Work. Dan kali ini adalah berkenaan dengan Model of Human Occupation, MOHO, Approach for Adolescent Client in Return to Work, yang disampaikan oleh Dr. Muhammad Sulaiman bin Murad. Baiklah, sedikit berkenaan dengan topik kita hari ini. Kebiasaannya sebagai pengurus kes, kita mengalami satu situasi di mana kesukaran ketika menguruskan orang berinsurans kita untuk kembali semula bekerja. Sebagai contoh, apabila adanya anggapan antara kalangan OB kita ataupun peserta return to work terhadap melakukan pekerjaan itu berubah setelah dia ditimpa bencana yang menyebabkan kurangan fungsi anggotanya. Macam sebelum ni dia okey, dia boleh buat lakukan kerja, tapi selepas daripada kemalangan akan ada satu tanggapan ataupun rasa perasaan dia, emosi dia terganggu, dan semestinya individu ini dia akan melalui satu fasa di mana dia kena jalani pemulihan. Daripada situ dia terpaksa untuk belajar semula untuk berdikari. Untuk contohnya kalau macam sebelum ni mampu berjalan, sekarang dia dah tak boleh jalan sebabkan kaki ni potong. Jadi daripada situ dia rasa dia dah tak kompeten untuk melakukan kerjanya. Sebagai contoh, kalau dia sebagai penyelia bangunan, management officer yang perlu banyak berjalan. So disebabkan tak dapat nak berjalan secara normal macam sebelum ni, mungkin dia rasa dia dah tak boleh kerja. So faktor-faktor macam ni mempengaruhi prestasi pekerjaan dia setelah dia balik kerja, yang juga mempengaruhi motivasi dia untuk nak balik kerja ke tak nak balik kerja. Mungkin mengganggu dari segi pelan kita lah untuk menguruskan hobi ni. Jadi semua ni insya-Allah akan terjawab pada hari ini menerusi Model of Human Approach ataupun MOHA yang akan disampaikan oleh Dr. Sulaiman. Dan sebelum kita menyelam lebih dalam tajuk kita hari ini, kita selami dulu serba sedikit latar belakang berkenaan dengan speaker kita hari ini. Bergelar doktor setelah tamat pengajian di Monash University Australia dalam bidang perubatan. Kini Dr. Muhammad Sulaiman bin Murad bertugas sebagai pensyarah kanan Pusat Pengajian Pemulihan Cara Kerja di Fakulti Sains Kesihatan Universiti Teknologi Mara UiTM. Dr. Sulaiman sangat beraktif dalam bidang kesihatan pekerjaan dan rehabilitasi, dan banyak sumbangannya mengeluarkan pelbagai research paper. Dr. Sulaiman telah menerbitkan sekurang-kurangnya 21 kajian, tak silap saya, terhadap occupational rehabilitation. Selain daripada menjadi pensyarah di universiti, Dr. Sulaiman juga pernah bekerja di hospital dan klinik dalam Department of Occupational Therapies dan menerima pelbagai anugerah, antaranya anugerah pekerja terbaik daripada Perumah Hospital, juga UiTM, dan awarded scholarship for oral presentation. Betul ya doktor ya? Okey, itu serba sedikit berkenaan dengan Dr. Sulaiman kita hari ini. Dan dipersilakan Dr. Sulaiman, the floor is now yours. Dipersilakan.
Okay, thank you very much, Mr. Taufik. Our welcome from Encik Taufik. So I a bit nervous berjumpa dengan you all semua, case manager, therapist. I think from Indonesia also join sesi ni. So first of all, like to thanks giving this opportunity to share with you all. I'd like to thank Mr. Zaidin, giving me this opportunity to share with you all. So my talk regarding model of human occupation, known as MOHO, actually is area of my study during PhD. At the same time, I will share with you all regarding the experience with our client, especially in return to work. And I hope that my sharing will benefit to you all, especially you all practice return to work, case manager, therapist, anyone that engage with a client in return to work. So my talk will be around 1 hour 45 minutes, and at the end, I hope that you all are able to participate, question and answer. It's a bit tough for me to look everyone. It seems that I looking my face only. Okay. So model of occupations to our client, return to work. So when this is my outline, first of all, I'm going to introduce return to work from what I know. Probably case manager, they are more better than me in terms of return to work, because they are engaged with the real client. They're involved with the employer, and also legislation talking about return to work and etc. And then after that, I will highlight model of women occupation, the theory, and also its evidence. It's very important that when we use MOHO in our approach, we have to know the evidence. And then I will reflect whatever the component of the theory. I will reflect with the assessment that available and relate it with case. So I bring together three of the case study that I want to share with you all. And these 2 hours is just exposure for you all to understand more. This is like introduction for you all. However, if you want to engage more with this MOHO, you have to do a bit reading, and probably in future, if we have time, we conduct a workshop together. Yeah. So when talk about return to work from International Social Security Association, that return to work is something is very important. It's a process, and it's designed to facilitate the workplace integration. This is very important. Workplace integration to our client, which is injured, having diseases, disorder, and etc. Yeah. So when they return to work, we try to fulfill their job demand. However, probably there is a limitation due to their impairment. And as a case manager or therapist, we have to take into account their individual needs. And very important, the environment, the workplace they are going to return back. Yeah. Remember, guys, that not only work. Remember that other environments such as at home or their leisure activity, we have to take into account, because this one it interrelate together. So this is very important. We have to take into account the individual needs and also their environment. So when talk about occupational rehabilitation, so the aims of occupational rehabilitation is to address worker safety and productivity. The bottom line, when we return them to work, is they must be safe and as a produce workers. This is the bottom line. When they return at industry, the productivity must be there. And when we make approach to them, we shouldn't deny their needs that classified by ICF. ICF have come out with the international classification from WHO regarding functioning disability and health. And very important, as well as selected frames of reference, so that they're able to facilitate to participate in work. When I talk about selected frames of reference, it can be one of the things that I will talk about is, for example, MOHO, biomechanical, cognitive, occupational, cognitive behavior, and etc. So all these selected frames, if we need, we have to use. So when talk about the international, what I'm going to talk a bit about the differences about ICF and MOHO. So when talk about ICF is a way we understand the effect of the the workers in terms of their impairment, in terms of their activities limitation, and also participation restrictions. We need to understand. We have to know what are the activities being limited, and also what the participation being restricted. So this is very important in terms of ICF. And ICF also lay down the importance of personal factors. This is personal factors that MOHO have addressed. And very important, the environment. So these the things when we handle our client, especially return to work, we have to take into account their environment and also their personal factors. And how about MOHO? And so about MOHO, when talk about MOHO related to the ICF, this is a MOHO, MOHO model. So MOHO model looking at the personal, for example, their volition, their habituation, and then we take into account their environment. When talking about performance skill, is about activity, limitation, and participation, similar to the ICF. Similar to ICF, but there is a difference. There is a difference from my research regarding ICF and MOHO. There is a difference between these. I will discuss more on this topic. So when talk about MOHO, is involve personal factors, which is volition, and also their habituation, environment, and performance skills. So I will discuss in detail about this MOHO. So when talk about what are the differences and similarities between ICF and MOHO, as we identify the difference between ICF and MOHO, similar. In ICF and MOHO, it is a client-centered approach. We need to understand our approach must be client-centered. The client's need and priorities. So when talk about ICF, it's more on we want to know the effects when they have impairment and relate to their body function. We know about the effect what they're going to face in terms of activity limitation and participation. But using MOHO approach, we understand in depth the person life experience. Because as a therapist or case manager, we need to understand in depth what the impairment they suffered relate with their life experience. When we know in depth about the person experience about their limitation and participation, we can come up with the program or intervention. So, as you all know, that this ICF is a universal model. Every professional understand ICF. However, in terms of MOHO, people who understand model of MOHO is an autism model actually. So if they understand the model of autism, they can use it. There's no harm that if you find that this MOHO, you able to practice it with your client, it's no harm that you can use this approach. But I have to tell you, this is from autism model. So when talk about MOHO, this is surveyed by National Board of Certification of Occupational Therapy. The most model that been used is MOHO, compared to biomechanical, neurodevelopmental, and also sensory integration. This is studied by USA NBCOT, and this MOHO have been practiced throughout the world, in Australia, in USA, in Canada, even in Malaysia, they practice it. In Spain, in there is a community, community of MOHO. I engage with the community. So sometimes even in Chile, South Africa, they're using this MOHO, and we have discussed together using the MOHO approach. Yeah. And who's the founder of this MOHO? The founder, we call father of OT, is Gary Wayne Pifhona. So he was the founder of MOHO, but he's only survived until 2010. But the legacy lives on. So actually, MOHO grew out from Dr. Gary's master thesis. Master is in mid 1970s. From his master thesis, and in mid 1970s, it been practiced, and then in 1980, it been published. This model of human occupation. When talk about MOHO, actually it's a theory. It is a theory. So when it's been practiced by therapists, it become a model of practice. This theory become a model of practice. That's why they're known as model of human occupation. So MOHO is intended for use with any person experiencing problems in their occupational life, and is designated to be applicable across the lifespan. So actually, MOHO not only for adolescent, but also from childhood. This MOHO can be used, and it is across the lifespan. So when talk about why I like this MOHO, because it's really established, and they have construct many assessment that relate to their theory. So almost there is 19 specific MOHO assessment, and the large number of document case studies illustrated in the use of MOHO. So even MOHO have come out with a textbook. Right now there is a 5th edition of MOHO. If there is so many editions of this approach, there is a lot of study being done. And then there is published papers and manuals that describe the implementation of program based on the model. And MOHO also have come out with they call it MOHO Clearing House. So you can actually Google this. I Google this view. Just short while I want to share with you. Hopefully, this is, if you got time, you can access this MOHO Clearing House. So from this MOHO Clearing House, you can see there's a lot of products. Products. This is my introduction lah. Bukan saya nak jual MOHO ni. This was introduction for you all. See, from this, there's a lot of assessment tool that cater for different type of condition and different type of approach. Because MOHO, there is 4 components, as you all know, as I told you just now.
Assalamualaikum. Interrupt sekejap.
Okay.
Tak nampak monitor tu, display.
Tak nampak ya?
Nampak. Terima kasih.
Tak nampak macam tuan?
Nampak kosong je.
Oh, nampak kosong dia. Okey, sekejap ya.
Ada skrin putih.
Oh, okey, sekejap ya. Thank you, Mr. Taufik. So actually, I have to share website, web browser. Okay, thank you. Thank you, Mr. Taufik. Sekejap ya. Oh ya mak. Apa dia tu ni? Okey, sekejap
Suara lagging ah.
Suara dia tak berapa clear kan?
Suara lagging.
Suara saya ke siapa?
Suara Encik Taufik kot.
Taufik. Sorry saya ke okay.
So far okay.
Thank you very much Miss Rose Miss Rose tadi. Okay, sekejap ya saya share. Okay. Nampak tak sini? Sharing Safari. So can you everyone?
Nampak
ya?
Doktor.
Nampak.
Thank you very much. This technology sometimes kena remind each other so that everyone benefit. So you can glance through this MOHO website. So this MOHO website actually there's a lot of products. A lot of products. You can see that product here. In terms of these products depend on the needs of your client. Some of your client, if you want to assess work performance, so you can download, not for free, you have to buy lah. You have to buy, not expensive, about $40 US. 40 US dollar for Malaysia ringgit is about 150 ringgit. But the very important, the developing of this manual and the manual from the theory of MOHO. So a lot of assessment, but I will share with you all assessment that related to return to work for client adolescent. This a lot of assessment, and also one thing that I like this more, some of this manual have been translated into other language version. So this thing that good in MOHO. So whatever the research that been done for that manual, it been highlighted here. And if you want to know detail in this presentation, I will not discuss in detail the reliability, validity, study being made. This is just introduction for you all. But if you want to know detail more about this MOHO, you can glance through with this website. Yeah. So I go back to my sharing, share content. Sorry guys, this is first time I use okay, nampak tak ni? Okay, everyone clear?
Yes.
Okay, thank you. So you can glance through during your sweet time through the website regarding the MOHO Clearinghouse, and there is a community participation. You can also have community participation where mail if you got something to ask with the people that engage using MOHO. So we can discuss in detail during community discussion. And there's talking about research. A lot of research been done with this model. About more than 100 studies have been done, and also I did my study using these tools, model of human occupation, and the conform and reliability and validity of MOHO assessment, and then documented the process and outcomes of intervention based on MOHO. And MOHO also established a textbook. A textbook is very important because in this textbook they discuss detail about the case study that they've been done, and what they have been done with the case study, and what the interventions or that in this 5th edition of MOHO. So when talk about return to work, I like this Young et al. 2005. So Young et al. Come up with the when talk about return work, there is phases. There is a phases. Young is a psychologist. She's a psychologist. So when talk about return to work, there is 4 phases. It can be off work, re-entry, maintenance, and also advancement. So when talk about phase one of work. So phase one of work, actually at no time the worker back at work. So this is where the phases of work, the injured worker go through rehabilitation. Rehabilitation, they go to physiotherapy, occupational therapy, they have a surgery or that. And then then talk about second phase, a phase of re-entry. This is the starting point. They recommend work at either pre-injury workplace or at some alternative work site. So this is the challenge as a case manager, as a therapist, to go to get back to get them back to work. So this is a re-entry phase, and also there is a third phase called maintenance. Maintenance phase is the goal status of his or her physical and mental function. So they have to maintain. This is also a challenges for the client themselves to maintain their physical and mental functioning. And then at advancement phase, this is the advanced phase where they're going to given more responsibility. So they're going to qualify for higher level job tasks, and they're having promotion. This is the phase that when we consider return to work, they already achieve. So our target to our client not only at phase 2, but it should be at phase 4 advancement, where they can attain promotion, given more responsibility. And I want to discuss when talk about these all phases. The importance of theory. When talk, what is the approach when talk about phase 1, 2, 3, and 4. This is the we call it disability management. That's why case manager come here. So case manager actually start at phase 1 already, and they will go higher to phase 4. And when talk about phase 1, this is a phase 1 that we use biomechanical, we use CBT, we use sensory integration, kinesiology approach, occupational behavior, and model of human occupations. From what I experienced, what I have deal with, is important to be used with the patient who are at phase 1 and phase 2. This we can use model of occupation, MOHO, at phase 1 and phase 2. And case manager, disability management, they're going to coordinate from phase 1 until phase 4. This is the return to work phase by Young. And I like Young because Young have come up with the phases which we easily work with. We can collaborate, OT, physio, with case manager, with counselor, psychologist, and etc. So actually, I did a study. And the subject that under my study is the injured worker with musculoskeletal disorder participate in return to work. So my study is more on prevalence of study. So I got 76 participants participate in this study, where the participants fall into 3 groups. So we have a criteria, participants who work off work, re-entry, and maintenance. So from this study, is a cross-sectional study, I found that yes, there is a significant difference in terms of occupational competency and also their negative emotional state when they are in off work and re-entry. So this is this finding highlight to us that we have to use model of occupation in these both phases of work and return to work. This using model of human occupations. And then I also did a study also with this 102 participants who participate in return to work in Malaysia scenario, because I I remember I sit down at the So Center at Kuala Lumpur or Tampang sana. I remember siapa yang engage dengan I tu I pun dah lupa. Sekarang ni dia dah jadi orang besar dekat So. So they are really helpful. We work together to understand. So we did this health status using ICF framework. So I using SF36. So from this study, I found that across different groups, significant difference were found in role, physical, vitality, bodily pain, general health, and mental health. But maintenance, there's no issue of these health. So this also highlight to us that we need to tackle these people who are off work and also at three phases. Yeah. So when talk about MOHO, this is talking about volition, habituation, performance, capacity. So these four components that MOHO emphasize, and what MOHO emphasize is competency, whether they are competent or not, and then what are their priority and what are their needs, which is their value. We need to understand them. So talking about volition is motivation to do things, and choice make with life. So when talk about volition, when what we want to return them to work, they have to be motivated. They have to be motivated. They must have interest to participate. This is called volition. For example, if we want to, for me lah, if I want to work as a lecturer, I need to have motivation. I must have personal causation. I must have interest. So very important. If injured worker, the volition is not there, it's difficult for us, especially case manager, to return them to work. And then habituation is a typical routine and role. Some of the injured workers, then when they off work very long, and they affect their routine. Even in our scenario, COVID-19, we being MCO. Right now, MCO by our government, you cannot move, you cannot go anywhere. Your routine being affected. True, routine will be affected. You cannot involve with your leisure. Some of us in weekend we go to have leisure, mountain bike, picnic with family, and this routine being affected. Even our normal, and if we cannot play our role as a worker, I will highlight you the case that I've done. You will affect them, and they will be unmotivated because it's habituation and volition is interrelated with each other. Normal person will be affected. How about vulnerable population? For example, that workers be injured for a long time, and the injury is multiple. So this person will be affected, routine and role. And then their performance capacity. When talk about performance capacity, it's about health and ability. Their physical and mental and their communication interaction. This is the performance they have to do at work. So if the performance be affected, sure, there is a link with their routine and role and the volition. Another component in MOHO, they call it environment. Environment is physical places and people interact. So interaction with their peers, their workstation, their equipment, their environment, for example, lighting, all that. So this thing interrelated. So as a case manager or therapist, we need to take into account the environment. So they all have to be competent, and they have to be must value all these things when we want them to return to work. So this is the more definition when talk about volition. So volition is the process by which persons are motivated what and choose what they do. They must motivate. When I handle cases, if there is 10 cases about return to work, only one or two have issue of volition. If the injury is not so bad, if there is a severe and they have a long off work and due to their multiple injuries, their volition will be affected. Their habit, a process whereby doing is organized into pattern and routine. So when we go to work, we have routine and we have habit. When I go to work as a lecturer, the lunch time is the best time for me. Because of what? Because I able to routinely talk with my peers. We have enjoy talking during lunch. This is a routine that during MCO, I miss that. When I discuss with my colleague, some of them already have a mind to retire early because their routine already affected. And I hope MCO will not go further anymore. No MCO 4, MCO 5, that, yeah. And then performance capacity. So performance capacity, the underlying objective mental and physical abilities and the life experience that shape performance. So if you have problem in your mental, you cannot process. Mental is about your cognitive process. And you have problem in your physical, for example, coordination, balance, all that. If there is an issue on this performance capacity, affect your performance. And also the environment. Environment also we have to take into consideration their social culture, their political, economical, fund, and etc. So when talk about volition, I'm going to go in detail a bit about this volition, and I will discuss with you what type of manual assessment that can be done, that you can use to apply in your case scenario. So what one holds as important and meaningful to do, what one finds enjoyable and satisfying to do, include personal causation. There is something that causes you to work that particular area. For example, because of you are a breadwinner of the family, you have a lot of commitment. This is personal cause. There is a study, the younger workers who injured, workers who breadwinner, they have personal causation is very high. And then their value. If you don't value your work, there's something wrong with you. For example, you not value going to work and you go back, you come late, you not finish your task. Probably there is issue of value and also interest. There's no interest of that. So as an therapist or case manager, we need to understand our client in terms of their volition, in terms of their values and interests. So this is called. So personal causation, I go a bit detail, is awareness of one's ability and the sense of how effective one is achieving what one wants. So you know your abilities, your strength, your weakness, and what you want to achieve in terms of your working career. This is the thing, personal causation. If you don't have awareness of your abilities, that will be difficult. So some of us, there is someone request, so I have to approve it. I don't know, Irani, Bakis want to request something. Okay, I don't mind. Boleh, boleh. So awareness of one's ability is very important. If it's like you mirror yourself, you mirror yourself. If someone working together with you, they cannot mirror himself, the weakness he have, it's going to be difficult. It's going to be difficult to them to improve. So personal causation. Sorry guys, kenapa tak boleh gerak ni? Oh, ada, sorry Mr. Taufik, ada apa ni? Oh, sekejap ya.
Kita perlukan backup sorry. Kita perlukan backup Dr. Sulaiman. Mungkin saya boleh minta Encik Zaidin dia ada slide juga.
Okey, cuba doktor tekan next slide. Okay, next slide.
Teman,
Doktor, mohon unmute.
unmute teman.
Mute. Okay, sorry. Sorry guys, tertekan pula unmute. Okay. So in terms of value, define what is worth doing, how one ought to perform, and what goals of aspiration deserve commitment. So if you find your work, your task is worth doing, this means that you are value your work. So when you value your work, you must have goals to achieve. You must have commitment. Even you, for example, I show these pictures, taking care of goat, kambing, from Indonesian probably kambing, tak tahulah panggil apa ya. This goat, these people, this fella, the value of his work, it is worth doing. I mean, whatever the job that is value is worth doing. Even bearing goods. So we need to understand and address our client worth doing in terms of value. Interest, what one finds enjoyable or satisfying to do. This picture I got from my friend, Mr. Ghani from Ipoh. So this fella, so OT have to do some modification regarding his work as lorry driver, even though there is a limitation, because he finds enjoy and satisfied with his work as a lorry driver. So sometimes, as a case manager therapist, we cannot change their interest because this is what they interest, and we have to value it. So, lots of evidence regarding volition factor and their impact on work-related integration. This from Brave Man, 1999, the volitional factors. Factors are positively correlated with return to work. So, when there is the volition factors being addressed, their chances to return to work is there. For Mantrap, volition is important to consider in setting treatment goals for work. So, when you want to return to work, the abolition, you have to consider the abolitions. If the abolition is not to up to the thing, the value on the abolitions, and the abolition is not there, it's going to be difficult for you to treat the goals for work. This from Eckerblatt. Eckerblatt's person who return to work have significantly higher personal causation compared to person who did not return to work. So if the person have personal causation, they have something there is a cause for them to work, the chances to return to work is high. And volition include interest, personal satisfaction, and value for career, affects the decision to return to work. So if your client have issue of volition, you have to address first in order for you to get them to return to work. So how as an OT or case manager knows, this is very important, important aspect, for you to see whether your client in terms of volition. So MOHO have come out with the volitional question. So volitional questionnaire is a method of observation. You observe them. There is 14 items. So when they do their daily living, when they work, when they have leisure, so you observe. So in this volitional, there is 14 items. So that is for rating scale, 4-point rating scale. So I highlight this because this scale, we can measure them objectively. We as an OT and case manager, we cannot document our analysis by subjective documentation. We need to have objectively documentation. So these are 4-point rating scale. They call the rating scale spontaneous, involved, hesitant, and passive. So you observe your client during you engage with them, or they do activities, they do rehabilitation. For example, like physiotherapists, they do, for example, strengthening their muscle, their strength, or that. During their training, their intervention, they can observe whether the client have what status of their volitional of their client. So this is important. For example, I highlight to you all this item, item 3, item 4, and item 5. Item 3 is tries new things, show pride, seeks challenge. So you have to read them, whether they are spontaneous. Spontaneous means that they show their behavior without support. They try new things without support. I mean, their volition is there in terms of try new things. Show pride. For example, they passive. If you rate them passive, means it does not show behavior even with support. Even with support, you give them motivation, encouragement, but they don't show their pride. The explanation in the manual is there. How to interpret all these things in the manual. So I highlight here because if they score spontaneous, you can rate them as 4. If they involve, 3. And if they hesitant, we rate them as 2, and passive as 1. So when we come out with a program intervention, it can be individual intervention or group intervention. Then after a few sessions, you can read whether there is a progress. So as an OT and case manager, so when we do documentation, we are able to measure objectively. Objectively. So this is the form. If you want to more detail of this volitional questionnaire, you can go to the website. You can buy about $40 and you can download. So this is the items that we want to understand the worker volition in terms of whether they show curiosity, initiate action, try new things, show pride, seek challenges. All these 14 items, and we have to rate them whether they are passive, hesitant, involved, spontaneous, and you can put objectively by figures. So spontaneous 4, passive is 1. So during your session, there is a progression. So you are able to objectively measure your volitionary of your client. This I'm talking about habituation. Habituation that I have highlight to you all is your habits and rules. So if you injured and you return to work, if you unable to play your role, it will affect you. It will affect you because I experienced. I will share with you case study in terms of habit and roles. And thought how habituation is people organized doing recurrent pattern that make up much of daily routine. So this is a daily pattern they do. They connect people to and makes them functional with their familiar context. They regulate the pattern, familiar, and routine, allowing people to automatically recognize and respond to features and situation in the environment. So habits. These habits are acquired tendency to automatically respond and perform certain consistent ways in familiar environment or situations. So in terms of habit, this is my experience. This is my experience I did in Pusat Pemulihan Bagi, Rehab Center Bagi. So there is a mosque. There is a mosque where normal people also pray over there. They perform Friday solat, Friday praying every Friday. So not normal people can go inside the mosque because there is a ramp or that. There is a stairs. There is a stairs. But people who are wheelchair bound, they are unable to perform. They pray at side of the drain, longkang, longkang. So, as a therapist, using model of human occupation, so these people are unable to practice their habit, their routine. As a Muslim, pray at the mosque. So I suggest the bagian Muslim, the managing, to assess their architectural barrier, and recommend them what are the modification they need to do. The objective is to make this our wheelchair bound person to practice their routine, their habit. Dia as a Muslim praying at the mosque on Friday, especially on Friday. That is a orthodox thinking in terms of the management. They reject my recommendation because they said when you bring wheelchair inside the mosque will be a najis, kan? Dia cakap najis, kotoran, tayar kena tai kucing dan sebagainya. So tak boleh masuk dalam wheelchair. So, I told them, this person wheelchair is like their lower limb, their limbs. They have to mobilize. They have to move by using the wheelchair. So I fight with the management in a scholars discussion, in academic discussion. So I recommend them to come up with modification and accessibility where they can do ablution, they can pray, they can take wudu, they can wash, there is water, they can wash their wheelchair, they can go up to the mosque, and there is a corner for them to pray together with the normal people. So they buy my suggestion, and they approve that certain modification we have to do in order for them to practice their solat, their habit, their routine, at their place at the mosque. After they able to pray, the wheelchair person, the handicapped people able to use the ramp, do ablution, bring their wheelchair inside the mosque. So I interview one of the case said to me, it's like I have I have a second life in this world. It's very great thing. We can done with them in terms of return them to their habit and routine. This is an example I want to highlight to you all. So in terms of rules, if you have if your patient, your client have undergone rehabilitation, conditioning work hardening, and if they are unable to practice their roles, it will affect them. So this is evidence. Talk about evidence, lot of evidence in terms of by Cliff Horner. Long-term work role disruption, identification with sick role, and absence of functional routine are barriers to work success. If they unable to play their role at their workplace, affect the success. Person who return to work are better able to place their work role expectation than person who do not return to work. And a majority of the participants with previous work roles value highly return to work. So if you want to place them return to work, you need to understand their role, what their role they play at their workplace. So in MOHO, there is a manual. There is a manual. This is a semi-structured interview. Interview for the injured worker. There is 6 areas with 16 items. And then there is a 4-point rating scale. So we are able to rate in terms of role, worker role, with the workers and with our client. So these the areas. There is 6 areas with 16 items. For example, I focus on this, their roles, habits, role habits, appraise work expectation, influence of other roles, work habit, daily routine. So we need to understand their roles and habit while when they return to work. So this is the indicator. We can rate them whether they are strongly support, whether they are support on the support. There is interference, and also there is strong interference when they return to their previous employment. This is important for us to understand our workers by interview when they return to work. So there is a case study I want to highlight to you all. This is a case study. Mrs. R, Mrs. R, 48 years old, married, has a son, studied at boarding school, suffered CBA in March 2000. So she's went through a work hardening program at Bangi, PLPP Bangi. Previously, she working as sergeant, warder in the prison. This is a female prison at Kajang. So previously, her job description involved with planning and organizing duty and timetable for the warders at Kajang, female prisons. So at the same time, he have to do a round to check the warders under her. So when we finishing our work hardening, and she already able to perform the job description as a warder. So I sent back her to home, to Kajang as a warder. Unfortunately, the role she play is only as an office boy, mainly photocopying paper. So when I interview her, she have a problem in terms of role. She have what they call it, significantly interfere, and there is interference of their of her role. So when I interview, there is the issue of roles and habit, and it relate to her volitions in terms of her interest and their motivation. So there is a interrelation with this because she unable to perform her role as a warder, as a sergeant over there. She cannot perform. She only been gazetted by the manager as a photocopying paper. So her mind only want to resign from, want to option early as a warder. This thing highlight to me that I need to see the higher officer over there who responsible for her. So I discuss and advise to give her more challenging job and not as an office boy, because this will affect his participation in return to work. Yeah. So our role is not ending at the rehab center. We have to negotiate. We have to advise the higher officer to give chance for her at higher level of playing her role as a warden, as a sergeant. So this thing help us using this using the is apa worker role interview. So the worker role interview able to detect whether there is a strongly interference in terms of their roles and habit involve their routine, etc. So it's like something that we can discuss with the higher authority at workplace, at their workplace, to discuss, because we assess them objectively. Okay. Performance capacity. Performance capacity is very important. Is experience instead of being simply an artifact or consequence of doing something. Is central to how people perform. To learn any performance, one must discover how it feels, the life experience. So this is called performance capacity. So performance capacity depend on your physical and your cognitive ability, and also your communication and interaction. So when we do things, we exercise within our capacity. For example, like this our client. He has an issue of perform his ability and his interest and his value driving himself. So he's a spinal cord injury at level of C766. Need modification of their steering. So as an OT, we need to understand their performance capacity, and we want to improve their performance for them to perform within their capacity. So some of we use modification and etc. for them to drive independently. So there is a studies by Keith Horner and Bridgman. There is a limited process. There is limited motor, process, and communication skill are barriers. So there is the limitation of motor and process. Process involves your cognitive and communication skill. These are the barriers to work. So as an OT and case manager, you have to understand your client, their limitation, the process, and we have to come up with a program intervention how to improve their motor performance, process, and communication skill. So in this performance, when we talk about performance, we can, for work, especially in work, we can use this AWP, assessment of work performance. So assessment of work performance, that I like using this AWP because we can use activity that within the interest of patient and their ability, when we can assess. The process of assessment is using observation. So three things that we assess using AWP, which is motor skill, process skill, and communication and interaction skill. So there is 14 skill item that we assess using AWP, which is domain of motor, domain of process, and also communication and interaction skill. And very important, with this AWP, there is a rating scale. This rating scale we can measure objectively. Yeah. So in terms of motto, if you want to know, is we want to observe action of our client. So it's involve posture, mobility, coordination, strength, and physical energy, and then process skill. So involve your cognitive. So mental energy, knowledge, temporal organization of space and objects, and adaptation. Yeah, this is the domain of process skill that we're going to assess of our client. And then communication interaction skill. This is the component that involve physicality, language, relations, and information exchange. So what I like using AWP is that we can come on activity, then we observe them. And we observe them, yeah. Then we rate them. From that, is a baseline. If the patient have a problem with the motto or the process key, this is a baseline that we can come out with the program of intervention to them. Yeah. The rating scale that in this AWP, so is like an indicator whether our client competent with their performance, whether there is incompetent performance or limited performance. And then if there is a questionable performance, it means that the performance of the work task is not fully competent with respect to the parameters. Yeah? So we can rate them with these 14 items. Yeah? I will show you one video. This case is case study that been diagnosed as cervical spondylitis with hemangiopenia plus right middle finger abscess. So as a therapy, we come out with the activity, then we assess them. We assess them. Okay, we are so with this when talk about, okay, I'll show you the thing first lah. So in terms of motor process, in terms of motor process, communication interaction, you rate them. You rate these ladies. So I'll show you the video. Nampak tak semua? You can see the video?
Belum start kan?
Okay. Nampak tak semua?
Nampak.
Nampak.
Alright.
Ada bunyi ke doktor sepatutnya?
Patutnya ada bunyi. Bunyi dia tak berapa kuat. Saya dah try tekan. Okay, kalau tak nampak, you tengok saja dia punya aktiviti tu. So you try to rate this lady. So we come out with the task of packaging. So you can see, nampak video ni, okay, packaging. In terms of motto, in terms of press setting, in terms of communication interaction, what are the status is ready. So the activity is involved packaging. You can see that there is an issue of coordination. Yeah. Trying. Yeah? So even the package is not so light, so heavy, not so heavy. You have difficulty. Yeah? In terms of perform this packaging. So, for example, like case manager, you come into a situation where you want to analyze the performance of the client, the intake worker, in terms of tasks that the job demand needed. So, as a case manager of therapy, you can assess using this AWT. It's like documented auditory indication. You know your status, you know your client status in terms of work performance. So, very important before you come up with the task, you must have structured tasks. For example, like I think you can see coordination problem usually drop because you can see the direction is spondylitis, maybe there is issue of nerve being affected. Is there. So this is the way that we are able to assess our client in terms of their work performance. If you see communication and interaction, there's no issue. There's no issue. This lady able to interact and communicate. This video taken by my PhD student. PhD student doing PhD right now. Mr. Kayin. So you see, reaching, he have problem of reaching, balancing. So when you want to put to the timbang, weight, measure weight, there's issue. Ada banyak dropping there.
Satu sengkat.
But in terms of cognitive, in terms of processing, she understand, deeply understand, it's not issue. The only problem is the motor, motor ability. So in terms of the task, you have to understand the job task of packaging. So there is a sequence you have to really come up with the sequence, not only packaging but also binding it again. Okay, so in terms of coordination, we got a lot of training needed for this, especially fine motor there, fine motor, coordination, balancing.
Kalau susah tak jadi pun tak apa. Cuma penyekkan dia.
In terms of understanding, processing, there's no issue. Because you already know the condition, right? The water conductivity with hemangioma plus right into the accent.
Kuat sikit.
And also you can see there's a lot of muscle, there's a muscle weakness.
Okey. Cuba tunjuk sikit.
You can see the upper hand tu. It's like ada masalah. So when there is a task of mobility, sure, from one place to another, he has a problem in terms of balancing.
Okey.
Okay, so you can read together. So from your observation just now, you can read. We know already the case. There's no issue. There's no issue of processing and also processing skill and also communication interaction. There is only issue of motor skill. You can see that we can read she at the level of 1 in terms of strength, physical energy, coordination, and coordination. There is a questionable performance in terms of coordination, mobility. Probably mobility, if we can improve her mobility using aids and adaptation of that, and then posture also, there is a questionable performance. So this is the way we rating. So this is the indicator. The score of motor skill is 11. Maximum is 20. So with this baseline findings, you can come up with a plan intervention. What program you want to do with this lady, and then you can see the progress. If she able to achieve at level 4, it means competent performance. It means that we can see there is a progress. As a case manager or therapist, the documentation is very important rather than subjective comment. So this is very objective that we are able to recognize their performance. This is okay. If there is a question regarding this AWP at the end of this session, you can ask me. Okay, one of the manual in terms of occupational, in terms of performance, MOHO have this occupational self-assessment. Occupational self-assessment is a self-report. Self-report. Actually, OSA is a general assessment regarding their functional daily living. Their not only their work but also throughout their daily life. So it's a self-report where in this OSA we can assess what are the needs of the client, what are their priority. This is for adult where there's no issue of mental problem or etc. So we can use OSA, OSA, opinion self-assessment. So OSA is a way for us to understand our client, what are the issue, what are the problem they're having difficulty, and then what are the thing that they want, that is very important to them. What are the performance, the issue they having, and then what are the thing that's very important to them they want to change first. This is client-centered approach, where the client read the thing, then they come out with the what are the, we can detect what are the things that very important to them, then what are their priority, what their priority. So there is, for example, like, so this is the three domain of areas. So there, the areas is about themselves and also environment, right? And also about the environment. So from this, it's like a starting point. This also is like a screening tool for you all. If you having a case, adult case, who having issue of physical problem, right? So this is a way you want to understand your client in terms of their daily living, not only work but also when they go back to their home and etc. So this we want to know their occupational performance, whether they are competent or not, and what are their priority, what their needs and their priority, what they like to change, what the thing that they like to change most. So I did a study with the spinal cord injury patients, spinal cord injury patient with my master student Siti Nohamiza. So we conduct occupational based intervention where we investigate 12 of them spinal cord injury using this OSA, occupational self-assessment. So when we analyzed 12 of them, we found that this the thing the most of them, 7 of them, have problem accomplish what they said to do. 7 of them, and then this one the most priority. The second priority is the basic things they need to live and take care of themselves. The 3 of them give as a priority. These 2 things, when we accomplish what I set out to do, and also getting where I need to go. Getting where I need to go is their priority. The third priority. The first priority is accomplish what they set out to do. The second priority is the basic thing they need to live and take care more on ADL, and also where to go. When you want to mobilize, when you want to go from one place to another, there is something that become their priority. So when we conclude, this priority is more on volition, environment, and also performance, their mobility. So this domain that really affected to them. So when we found, we know already the domain of that they have a problem, they have priority and needs. So we come up with the individual session and also group session. So I highlight with you all one of the case. Mr. Ash is quadriplegia. He is 36 years old. Injury of a level C6 to 7 due to motor vehicle accident. So we as a therapy, we know already when involved of C6, C7 is involved upper limb. They can do only elbow extension, only finger extension. They have problem of wrist flexion. So a lot of issue in terms of mobility, independence of daily living. We able to find out with this case. We using OSA. So we come up with individual session. So we want to solve in our program intervention with them. We want to solve especially their basic task of living. Basic task of living. So we have individual session with them. So I want to share with you the Mr. Ash, what we do with Mr. Ash. By using the OSA, we already know OSA. So Mr. Ash have problem of eating. So because of the C6 and C7, Mr. Ash unable to grip the spoon. When he eat easily apa ni, dia punya plate tu move. Bila move, so we come up with the apa ni yang stick yang tertampal dekat plate ni, dekat dia punya plate, so the plate not move, and we come out with the velcro spoon so that he can eat using spoon, that he can bring his food to his mouth. And he also got problem of writing. So we come out with this aids where there is a pen holding to the persons. Nails, they are unable to cut the nail because they have problem have finger grips. So using only her palm to cut his fingernail. So using this SSD device to address this basic issue of cutting fingernail. Using special brush to brush his body, and he can do independently. So I have individual session with them. I probe more individually what the basic daily living that he want to solve. So we as an OT, our case manager also can come up with this solution for them using OSA. And then transferring, there's a problem of transferring where he want to mobilize one place to another. So problem with him, he need assistance. We need assistance to people to carry him from wheelchair to seat of the car. So we have to teach them technique of transferring. And then you know that C6, C7 have problem of finger extension. So when they do typing, they have problem because they cannot push the keyboard because there is no finger extension. We develop aids for him to type, do typing in keyboard. This is the example of the things. And also we do education session, we do in group. So whatever the needs of the group, we come up with the session of education. In terms of, for example, they want to know about sex among spinal injury people. They want to know more about sports. What are sport available for spinal? So we call Mr. Rosley is a field staff involved in classification and involved in sport for disabled. He giving a talk. What are the sport available for spinal cord? This from the client who have spinal cord injury. So we share group education group together. Job opportunity and driving also, they want to know about driving for disabled. Wheelchair, how to use wheelchair, and also some of them they want to return and they have a house. How the wheelchair in terms of dimension of the home when they want to use wheelchair, what are the spec, the spec that suitable for them. All these things we conduct in group education. And then one of the requirement, what are the session that they badly need is a home visit. So as a therapy and case manager, you need to have a home visit. And this is the thing that we can identify barriers that affect their performance. So, and then you can suggest modification, and then you can collaborate. Some of them need assistance in terms of resource. So when we do visit, we assess what are their barriers, what do they need. So I with my master student, we have a visit all toward their home, and we come up with the suggestion of modification and what are their problems. So a lot of problem when talk about accessibility, mobility at home. There is a lot of barrier. So we give recommendation. For example, like this picture in terms of toilet. Toilet, their dimension, there is a barrier for them to access. There is no rail. And then mobility of the wheelchair. So we give recommendation and suggestion for them. For example, they need a rail for them to transfer. Before that, they told us this is done by the mother. Mother, we want to transfer. Mother have to angkat. They have to lift the client from chair to the toilet seat. And the mother also having problem of cardiac problem. So this is the thing that we give suggestion what to do, what did modification at their toiletry. When they work, there is also a problem of accessibility. They need ramp, so we come out with the solution. What type, what of the ratio of the ramp for them to mobilize. For example, the ratio here quite high, 1:7. By right, 1:15 is the best. So we come out with a drawing. And plan for them to improve their mobility. Stairs, some if you make a visit for urban area, there's like our culture Malay, we living room separate from the kitchen, and there is stairs from kitchen to living room. This is the problem they face. They are unable to perform their daily living in terms of cooking, doing domestic, going to toilet, and etc. So we give suggestion. So whatever we suggest, we play our role by writing to the person that if we find that can help them. Even we write to the Wakil Rakyat. And then Wakil Rakyat is able to help with our suggestion of that. For example, they agreed to provide computer accessories. So we write to also. They agreed to provide transport board, and then some of them they have money. They have money. The only thing they don't know what to modify for their client, their children, their son, to mobilize independently. So some of the suggestion they do by their own. They have money, but they only The only thing they don't know what are modification needed for their son. So we take action. Okay? And then we follow up session. So, a lot of follow up needed for them, and then a few session follow up then for us to close every case with our occupational based intervention. I call it occupational based intervention. This is an example. We have problem. The Mr. T have problem for transferring, so he need a transfer board. Need transfer board, and then we train them using transfer board from chair to wheelchair. I show you. So the example. Because the injury is quite high. He lost his balance, his trunk balance, his grip, he unable to do gripping, flexion. So be careful when you train with this case. They have no problem. So you have to be standby there. You have to be standby there. If they lost balance, you are there. Okay, this example that I like to you. And then the example, I like this with my master student have done very well. Amiza, she come up with this solution that really helpful for the client. I show you the video. On. Sekejap ya. Okay. This video, I think you can apa ni, go through this link by yourself. You've got time. Because he got problem of finger extension. Finger extension, he unable to touch the keyboard. So we provide aids for him, for him to independently do tasks using keyboard. You can after the session, you can go through the YouTube. Okay. The last topic I want to share about you, the environment. The environment is very important. So it's about physical and social, specific to the context which one does something at work, at their home, at their leisure activity, and also culture can be one of things that influence in terms of the environment. So environment is very important. So in terms of evidence, a lot of study when talk about environment, lack of social support and negative social environment in the workplace are identified as barriers. So if there is a problem of social support at the workplace and there is a negative social environment at the workplace, this is a barrier for employment. This is my experience also. I did one case, spinal cord injury, but she got a problem of hearing, hearing problem. So I placed her in a Sony, in Sony company, doing work as assembly worker. So because of hearing problem, she unable to communicate with their peers, with the friends at workplace, and become alliance person at the workplace. And the workers' perception with this case, sombong, probably what they call in English, sombong. So one of our role as an OT, we have to talk to the peers and to their colleagues yang kerja kat situ tu while they're working. So we have to talk to them, give awareness and understand the condition of the client. The work social environment can affect willingness and ability to return to work. So workplace environment is very important. Even though we have improved their performance capacity, if the work environment is not there, they cannot sustain. They cannot work. So sustainable is not there. They cannot sustain working at their workplace. So in terms of MOHO, we have this worker environment impact scale. Worker environment impact scale is actually to determine the qualities and characteristics of the work environment that impact on the work performance. So we want the approach that usually we do is more on therapies. We come there, we assess the workstation, we identify the hazards for that particular workplace. But this approach is to determine the quality and characteristic of the work environment that impact on a worker. It means that from worker perspective, for the client perspective. So we want to know from client perspective regarding the characteristic of the work environment, whether satisfied to them. So that we use this work environment impact scale. So candidate, what are type of candidates to work? People, client who having physical disabilities, psychosocial disabilities, and currently employed, but who are not presently working but are anticipating return to specific job, you can do. This very important in terms of understanding your client, in terms of the environment, whether the environment have impact to the client. Therapists and case manager good if they can use this ways work environment. So in ways there is 4 domain that we look into. The approach that we use semi-structured interview. We interview them in terms of physical space, in terms of sensory qualities, architecture, the ambience and mood, and then the object, the property object, physical amenities, meaning of the object, social group, more on interaction of co-workers, or work group membership, supervisor interaction, or work role standard, work role style, interaction. So this is more on social part. So we want to know in terms of interaction with co-workers, supervisors, is there any issue? Whether it is strongly support, interferes, factors strongly interferes. So if there is an issue of interference and factors strongly interfere, so we need to highlight to the majikan, the company, employer. So this thing, we as a case manager or therapist, if we found that from our interview there is issue with this domain, if there is indicator 2 or 1, so we need to discuss with the employer. So occupational form, time demands, task demand, appeal of work task and work schedule. This is more on occupational form. The demands of the job, the time, whether they can complete the task demand is it within their capability, appeal of work task, work schedule toward them. So uh, we need to interview the client that we have returned to work. So this is an example of form talking about the 21. There is a 17 item with the domain, and there is a rating. Whether it's strong supports, interferes, or strongly interferes. So if there is indicator of interference and strongly interfere, we should come up with we should discuss with the employer manager how to resolve it, how to come up with the recommendation. So this is the example of the form. There is 17 items with 4 domains. 4 domain. And so the interview process, first we need to understand, we have to obtain appropriate background data and we discuss with the employer. I know that especially case manager, they have cooperation from the employer. So you should discuss before site visit what you do over there. And then it's about 30 minutes only. Interview with your client. And then you must rate. That is this the form that I provide to you. This is the form that you need to rate. Then you have to utilize the information from the interview, whether you want to improve or to modify. Some of your client, some of the suggestion, some of the things that need to be improved or to modify. This is the form at the end. The environment, what the environment facilitate them to return to work. You have to state the strength, the qualities of the environment here, and then what are the challenges they facing in their work environment, and then recommend reasonable accommodation. What are the thing you want to recommend? You put here what the reason you want to recommend. Goals the worker will pursue. So if you recommend something and the employer agree, the client must pursue. What are the discussions that we made? And this is like agreement between the client and also the employer. We seems like a middle person for us to make sure that the environment within their needs and that they enjoy looking at that place. So this is a case study I've done. This case study is diagnosis as relapse schizophrenia. And then she's undergone medication and got an occupational therapy service. And when returned to work, she's working at Pertama Shopping Complex. She's working at promoter. She's a relapse schizophrenia. So when we interview her. So there's issue of, if I'm not mistaken, I lost the thing. So there is issue of interaction, supervisor and work in group, and also supervisor interaction. There is a 1 and 2 there. And then from that, we discuss with the employer and how. That's why when we understand the environment issue from our client perspective, so we can do our role as a negotiator, advisor, consultant to the employer. So this is the work environment impact scale that can be used for client that has returned to work. This is the assessment tools that you can use. So Using MOHO, it's not only the theory behind it, but they have developed assessment tools. Even at the MOHO website, if you can go to the website, actually they have planned intervention. There is intervention that you can do when you're able to assess the client. Okay, I reserve the time. We got, I think I reached my session. Got 5 minutes. You all can ask any question regarding the tool. If you have something to ask me personally, you can contact me by mailing me. I provide here my mail here, and I welcome you all to have any question regarding this model of human occupation for client return to work. So anyone, you got any question want to ask me? Mr. Taufik ada di situ lagi?
Masih ada. Okay, menunggu to the floor for the question.
Yeah.
Anyone can ask.
It's okay. Anyone? It's quite tough for you all to digest all these things within 2 hours. My presentation.
Ya, betul tu, Doktor.
2 hours.
Quite heavy.
That's why I highlight you all the basic things, the usage of MOHO theory with the tools, the manual that have. But if you want, if we can conduct workshop, 1 day workshop using all half day workshop using all the manual is good. Or you yourself can go to the website, understand more. So any question from Prof?
Assalamualaikum,
Yeah.
Zul.
Yeah.
Okay. Yes, this is. Thank you very much for sharing about the usage of MOHO models, which is quite specific. But it's good to share with others how OT's thinking in doing our rehabilitation course. Yeah. Right. My question is, can you share about the successful rate of the research work, whether they could sustain the work after that? Can you get my question?
Thank you, Dr. Zul. Dr. Zul is my Dr. Zul is my friends from school, from college. My good friends. The successful rate is more on case series that I highlight to you all in terms of spinal cord injury that I did, occupational based intervention. That's why the successful rate based on the outcome measure that we measured. For example, like you using occupational self-assessment, there is indicator that we able to measure the outcome, and the rate is there. There is successful rate if you read my article, occupational based intervention for spinal cord injury. However, as you all know that we dealing with subject, patients, we have limitation. We have limitation to compare the control group, right? Control group. We did it more on case series. Case series. It's tough to get the numbers based on scientific sample size that. But our achievement more on case series, that I highlight just now, occupational based intervention for spinal cord injury with 12 patients. If you got time, you can read my article using this. Okay, hang on. Okay, with this case, this article, the article, impact of OBI program in relation to quality of life for spinal injury patients. So there is an achievement, but only limited to case series, not a control study. There's no comparing of control studies. But I value if case manager who involved in return to work come out with very specific intervention for using this MOHO and publish it. Publish it. It's very very valuable, very valuable, and it can be as a replication for us to go through with our intervention using MOHO approach. Thank you, Dr. Zul. I hope you got time. You can read this study that I did with my master student, impact of OBI program in relation to quality of life. They are using OSA. This is a client-centered approach. We want to understand their priorities and their needs. From understanding their priorities and needs, we can measure whether it's successful or not. Thank you, Dr. Zul.
Thank you. Congratulations.
So any question from the floor?
Dr. Sulaiman.
Yeah.
Zaidin here.
Zaidin, Tuan Zaidin,
I have several questions because during your presentation, you already lay out like how MOHO actually focuses on the three components that I mentioned earlier, the physical, the volition, the process, semua tu kan, Doktor? And the environment factor. It's just that majikan boleh gunakan juga ke assessment ini sebab there's a concern lah. There are some cases when we go for worksite assessment kan, we already did the assessment like functional capacity evaluation, we have the value there, but then again when we do functional capacity evaluation, dia tidak semestinya kadang-kadang very close to dia punya work punya environment. And then when they come back to work and when they did work trial, the question that is raised by the employer adalah whether there is an outcome measure that they can use to evaluate the worker in the workplace, since they are much more closer with the worker and they know the worker waktu tu lebih rapat. And then kalau tak ada, what would you suggest lah in order for us to provide, because yalah banyak kali juga dipersoalkan bila jumpa dengan majikan, in terms of kalau berada di tempat kerja, they want that objective measurement which we can actually provide lah, and it's actually a problem jugalah. Your opinion on that, Doctor?
Actually, when we do FCE, we have a limitation. We cannot really, the task, we cannot really simulate in our clinical setting. We cannot really simulate the task, the job demand of the worker done in their workplace. It is impossible to really simulate 100% that capture the work task of the job demand of the worker at workplace. For example, like I did the Joel using Walpa, but that is limited because we cannot 100% capture the real task, the real environment job demand at the workplace. However, that's why I introduced assessment work performance. Assessment work performance that I introduced just now. Assessment work performance is be able to capture what the actual task that they did and their workplace. Actually, we can bring that manual, if there is a procedure, there is a policy that therapists can assess work performance of the worker at their real job task at their place. But there must be a policy of cooperation between employer, therapist, and case manager. If they agree with that, we can use AWP, assessment work performance, to assess the real job demand at their workplace. Yeah. If your question just now asking whether they can use this thing or not, yes, if they understand the concept of theory behind the AWP, which more on model of human occupation. If they understand the theory behind the tool that being constructed, then yes, they can use it. Because when you bought the manual, there's no policy or statement to say you must be an OT, you must be an physio, or you must be an OT to buy this manual. If they understand the concept of the theory behind AWP, behind the theory, then they can use it. If they found, and then because the AWP really capture the and then the AWP, you can bring AWP manual to their workplace and really observe whether they are able to achieve their work performance or not. One other issue is probably there is the workers itself, right? And himself, herself, in terms of manipulating of the result. But there is a technique that I use when I assess using Joel. I assess their cardiovascular, their pulse rate, their BP, so that we can mesh their diagnosis and their performance based on the very objective indicator of heart rate, BP, subjective observation, dia punya whether they have commitment, they have consistent effort, consistency effort, all that. So mesh with all these things, incorporate with this thing, probably we can use the AWP in terms of because AWP is very objective as indicator whether they are able to perform in terms of motor ability, process skill, and also communication interaction. It depends on the condition. Probably if condition of back injuries, we're looking on the motor ability. If there is cognitive condition, we look more looking at the aspect of processing skill. Processing skill involve of cognitive and etc. I hope this can answer Mr. Zaidan punya question. It's very good question.
Yes, it answers. Thank you.
Okay. Ada lagi?
Tidak dia nak tanya apa? Tengok. Okay, dapat.
Ada apa-apa soalan lagi ke daripada peserta?
Ada lagi? Ada peserta?
Jika tiada, saya paskan kepada Encik Taufik.
I'd like to thank you all before Mr. Taufik take this mic for participate with me, and I know that it's very difficult to digest within 2 hours in terms of understanding the MOHO, but this is the introduction to you all in terms of the importance of MOHO. If you can bring it into your your way of documentation. When you return injured workers to work, very objective observation assessment that can be done.
Okay, thank you Dr. Sulaiman for the sharing on the MOHO approach. Actually, before the session start, saya dah did some research on MOHO, how it operates. So quite interesting for me, and saya ada lebih understandable dengan selepas daripada Dr. Sulaiman punya penerangan lebih lanjut. And before we logging off, so have a few announcement to make. First, regarding for the next series CME 7 session on 29 June 2021. So just embrace yourself because the speech will be delivered by our speaker from Thailand, Kap Kuka. Next, still promoting on our CDMP, Certified Disability Management Professional. So for those who want to join, please contact with Miss Nur Hashimah. As appeared on the screen. And for the international, participant can deal with Mr. Zaidin. So the contact number is on the screen. For the third news is about any updates you want to get about return to work or more information on our activities. So please do visit our social media page, Facebook, Instagram, YouTube. Also can search the internet, search for our website at rtw.sotso.weebly.com. And that's all for today, I think. And before we end our session, please everybody open your camera for the photo session. And need Zaidin help to take the picture, please.
Mr. Haznul will take the picture.
Okay.
Zaidin boleh stop sharing dahulu.
Kejap hang.
Okay. Okay, maybe everyone boleh buka kamera. Okay, saya dalam kiraan 3 ya. Saya akan ambil gambar 3 kali ya. Okay, 1, 2, 3. Right. Second picture pula. Ni. Okay. 1, 2, 3. Okay, last picture. Alright. 1. Start. 1, 2, 3. Okay, thank you everyone.
Okay, bye.
Okay, again, thanks again to Dr. Sulaiman for those who joined today's CDME, and hope to see you guys for the next CDME. And still don't forget to register for your attendance today. That's all I think.
Thank you.
Thanks sekali, selamat Hari Raya, tak terlambat lah. Selamat Hari Raya juga kepada Dr. Sulaiman. Sekali lagi.
Ya, sama-sama.
Selamat Hari Raya, Doktor.
Baiklah. Saya kira itu saja. So stay safe, stay healthy everyone. Assalamualaikum dan salam hormat.
Buat para peserta, jangan lupa untuk isi borang kehadiran untuk tujuan sijil. Bagi peserta-peserta yang hadir daripada KKM, kita tidak mohon ini melalui CPD MyCPD portal. So sila isi borang kehadiran supaya kami boleh isukan sijil kepada anda dan anda boleh daftarkan program ini di bawah unlisted program untuk markah CPD anda. Terima kasih.